All right, so this PowerPoint is not that aesthetically pleasing, but it has some good information. So I'm going to utilize this for our recap. It has a lot of the same information we already discussed regarding multiple myeloma and other related plasma cell disorders. But again, I like to review, I like to repeat, I like to represent. So let's go ahead and move forward with a recap on multiple myeloma and plasma cell disorders. Okay, so here are some of the highlights, or should I say the lowlights, of multiple myeloma. So what we're going to see with multiple myeloma is an overproduction of plasma cells, which cause bone destruction, high serum calcium, kidney failure, infections, and even change in mental status. So overall, it's a pretty nasty proliferative disorder to have. And um, we talked about Babs the crab, so we're going to think of C as calcium, R as renal failure, A, anemia. I forgot to mention that in this slide, but yes, they may become anemic, and B, bone lesions. So those are some of the important things that you need to remember with regard to multiple myeloma. So if you think back to your immunology class long time ago in a universe or a galaxy far away, we learned about plasma cell development and what their job is. So if you remember, normal plasma cells are usually the last stage of B cell development, and they are specifically, their specific job is to produce specific immunoglobulins. So we're going to have IgG, IgA, IgM, and then we've got the IgD and the IgE. So all of those immunoglobulins are going to be produced in response to immunological stimuli. So whatever our body needs, this is what we're going to get from our normal plasma cells. Now, sometimes things go wrong and we have these abnormal clonal B cells. These are going to produce clones called plasmacytomas. They produce an interleukin 6, which stimulates production of more clones. And that interleukin 6 also prohibits osteoblasts from rebuilding bones after it's been broken down. So we're going to talk about that here in just a little bit more. So I think we talked about this yesterday in our last lecture, but we have an incident that's about 5 out of every 100,000 people. Again, like many of our other lymphoproliferative disorders, we have a higher incidence in men than women. And in this case, we have a higher incidence in African Americans. Now, there are some environmental factors, radiation, agricultural chemicals, manufacturing industries, benzene, but also chronic conditions like rheumatoid arthritis, allergies, and infections can also trigger the development of multiple myeloma. So I know we have talked about this, but let's just briefly recap our pathophysiology. So what we're going to see is an expanding plasma cell mass. We're going to see our normal bone marrow replaced with malignant cells, resulting in a pancytopenia. So all of our healthy marrow or our healthy cell populations are going to be crowded out with these clonal plasma cells. We're going to have destruction of the bone cortex, bone pain from those lesions, compression fractures of the vertebrae, because as those bones are broken down, they become weaker. And then we may even see some plasmacytomas in other areas of the body. Plasmacytomas are kind of like conglomerates of these plasmacytoid cells or these plasma cells, and they just kind of stick together and form these little colonies throughout the body. So we're going to have organs, skin, and GI tract involvement with that. Not fun at all. So the problem with multiple myeloma is that rather than have a normal antibody production like plasma cells should do, instead those normal, healthy, functional immunoglobulins are replaced with large amounts of these useless immunoglobulin molecules. So we're going to have single immunoglobulin molecules of like G or A or D or E or M, any one of those. The problem with that is as these clonal plasma cells produce an overabundance of these useless immunoglobulins or dysfunctional immunoglobulins, we're going to see a hyperviscosity occur in the blood of these patients. So they're going to have blood that's kind of congested with all of these protein portions of immunoglobulins. We're going to see a decreased production of normal immunoglobulins, which is really the biggest problem of all because this is going to result in increased risk of infections. And this is actually the leading cause of death in multiple myeloma patients because the plasma cells that are supposed to be producing functional, helpful immunoglobulins to protect us in case of infection are now just making all of this, this useless trash. So yeah, it's a real problem for people who suffer from this condition. We call this a monoclonal gammopathy. We're going to see a couple of kind of things that are specific to multiple myeloma. We're going to see excess light chains, or sometimes they call this light chain disease, and those are going to be either kappa or lambda light chains. And remember, immunoglobulins require both light and heavy chains and all of their functioning parts to be functional, but instead we're just going to see an excess of these light chains without the rest of their functioning units to make a complete working immunoglobulin. Um, these are toxic to the kidneys. So if we think back about the hyperviscosity we just mentioned, what filters our blood? Well, it's our kidneys, and all of this excess protein buildup in the kidneys is going to congest them, and it's going to become toxic to them and start causing renal damage and renal insufficiency. Another protein that is specific to multiple myeloma are those Bench-Jones proteins. So Bench-Jones protein is going to be found in the urine of patients. Now, don't be confused. That is not the same as those immunoglobulins. This is a specific protein associated with multiple myeloma that is excreted in the urine. And this particular protein will precipitate out at 56 degrees Celsius and it will dissolve as the temperatures rise. So you bring it to boiling, it'll dissolve. And then as you let it cool again, it'll precipitate out. So not the typical behavior of protein with regard to heat and cooling, but so another thing we're going to see are those light chains, those excess light chains are going to cause red blood cells to stick together and form rouleau formations or rouleau morphologies within the peripheral smear. And we're going to see that elevated sed rate because remember, what we're looking for with the sed rate is to see how fast or slow red cells fall out of solution. And so when we have these rouleau formations, they're going to be heavier than a normal red cell would be. They're going to fall faster and further in a shorter amount of time and therefore give us an elevated sed rate reading. We might have deposits in the organs, in the GI tract, in the skin. So we call that amyloidosis, and it can actually cause heart and kidney failure. And we also might have an autoimmune hemolytic anemia and bleeding disorders. Now, so it's crazy. I mean, when you see this these immune cells producing things that are supposed to be helpful and then they become harmful to the body, this is a real problem. Okay, so let's talk about this bone destruction because there are a couple of mechanisms that influence that. So if you think about normal bone structure, our bone is constantly breaking down and then our body is rebuilding it. That helps us maintain structure, integrity, strength in the bones. Our osteoclasts are the cells that are responsible for breaking down the bone matrix. And in order for those osteoclasts to be triggered or signaled that they need to do this job, there's something called an osteoclast activating factor. Unfortunately, these malignant plasma cells overstimulate the osteoclast activating factor, and that stimulates the osteoclasts to break down the bone. Because we have rapid breakdown and kind of, systemic breakdown of the bones, we also are going to have an elevated serum calcium level because what are bones? What do they have a lot of? They have a lot of calcium. So as you're breaking the bone down, the calcium has to go somewhere. It goes into circulation in our serum or our plasma. Osteoblasts are inhibited by the interleukin 6 that is also a stimulator to produce more clones. So that interleukin 6 that is associated with the plasma cells causes it to make more copies of itself, but it also inhibits osteoblasts from rebuilding the bone that those osteoclasts have broken down. So now we have rapid breakdown and no rebuild. What that results in is lytic bone lesions, and that can cause pathologic fractures. So instead of having strong, healthy bones, we get weakened bones as that matrix breaks down. And again, that hypercalcemia or elevated calcium blood level causes abdominal cramps, muscle weakness, kidney failure, and altered mental status. Now, if you think about muscle function, calcium is imperative for muscle function. And when we have just crazy, weird circulating calcium and it's not going to where it needs to go, or we have an overabundance, I mean, it could cause things even like heart failure. If your heart muscle isn't able to access or utilize your calcium, or you have too much of it, it's not a good thing. Okay, so some of the diagnostic tests that we have previously talked about are going to be that protein electrophoresis. Now, we can do that on serum or urine. And what we're going to see in that protein electrophoresis is an M spike in the gamma region of the gel. If that M spike appears, we will then continue on to do another type of electrophoresis called immunofixation electrophoresis. Sometimes it's just called immunoelectrophoresis, but we call it IFE. And that is going to help us identify the monoclonal antibody in the serum or the urine. The CBC and DIF in hematology, we're going to see a low hemoglobin, but it'll be a normochromic, normocytic normochromic type of anemia. So this could be kind of fall under that category of anemia of chronic disease. This could be, we could see white blood cell and platelets decrease because of that suppression of the bone marrow and that overproliferation of those plasma cells. And we're going to see stacked coin or rouleau formations with our red cells in the peripheral blood. So plasma cells are in fact part of the lymphoid line. They have a very specific job in terms of our immune response. But when we look at these patients with multiple myeloma, we're going to see a lot of circulating plasma cells. We're going to see even more plasma cells in the bone marrow. And this is a picture of a plasma cell. This is not my favorite representation. I really like it when we have a textbook cell here, but what a normal plasma cell would look like is you'd have this darker blue, kind of more pigmented cytoplasm, and then you'd have an eccentric, nice, big, round nucleus that kind of looks like a little eyeball looking at you. But what we do see here as well in our peripheral blood is are these rouleau formations. Now, don't be confused. When we are in the monocellular layer of the slide, we still see separate cells, but we see these rouleau formations. And when you know you're in the monocellular portion of that smear and you see these rouleau formations, you recognize that these are true rouleau versus moving too far into the thick portion of the slide where cells are forced to stick together because they're just too close and they don't have enough room. They can look like rouleau, but they are not true rouleau. So when you're looking at something and you think you see rouleau, be careful because you want to make sure you're in the proper area of the slide to recognize it. Okay, so another recap of our protein electrophoresis. So to the left here, this is a normal protein electrophoresis. The very first spike we're going to see is albumin. Then we're going to have our alpha 1 and our alpha 2 region, our beta region, and then this last area is our gamma region. So we are going to have kind of like a big spike at the beginning for albumin, because think about our serum. Most of our serum or our plasma, the main protein there is albumin. That's the most abundant protein in our plasma or serum. And we're going to have a couple of other important proteins down here. But in the case of multiple myeloma, we're going to see a gigantic spike in the gamma region, and we call this the M spike. Some people say the M spike stands for multiple myeloma. Some say it stands for monoclonal gammopathy. But if you look at it, it kind of actually looks like an M as well. So the first spike of albumin is the first spike of an M. It comes down and then it comes back up to the spike in the gamma region. So you can try to remember it in any which way you want: multiple myeloma, monoclonal gammopathy, or just it looks like an M because you have a spike in the beginning and a spike at the end, kind of those peaks that M's have. Okay, so if we do have an M spike, that is going to cause us to move forward with our immunofixation electrophoresis. And we're going to be looking at those light chain populations to see what kind of monoclonal gammopathies are present. So some other diagnostic tests we might use. So obviously plasma cells, or sometimes they're called plasmacytoid lymphs, are a form of plasma cell leukemia. They're going to have an elevated SED rate like we talked about. Our bone marrow is going to look like sheeting of those plasma cells on the biopsy, and then an increased number of plasma cells in the aspirate. And remember, when we are looking at our bone marrow, we utilize that biopsy to determine cellularity. And when we use the aspirate, we're looking at population. So what is the morphology of the cells present, and what type of cells do we have? So what we might see in that plasma cell, or in that bone marrow aspirate, are bizarre multinucleated or immature cells, maybe a high or increased number of plasma cell clones. So that's what I would expect to see in a patient with multiple myeloma. Now, the degree to which you see these things is really going to depend on how advanced the disease state is, but you would expect to see at least some degree of all of these things in a patient who has multiple myeloma. Okay, so a couple more diagnostic tests. So we've moved on from hematology. We are going to be looking at chemistry tests. So because of that kidney dysfunction, we are going to have an elevated BUN and creatinine. And that's because the kidneys, again, are unable to clear that excess protein and that excess calcium that's in the serum, or the plasma rather. Again, we're going to have that elevated serum calcium, elevated beta 2 microglobulin, and an elevated CRP. Now, we haven't really talked about CRP. This is called a C-reactive protein, and it's also an indicator of inflammatory processes, just like the SED rate, but this one's a little bit more sensitive and a little bit more specific. We can use this in fact to also kind of measure some cardiac issues as well. So CRP is going to be important, beta 2 microglobulin, elevated calcium, and our renal panel is going to show some level of dysfunction or some elevated nitrogenous waste products. Urinalysis is going to show excess proteins, and it may show casts because of the protein matrix that make up casts. We're going to talk about that in our next unit of urinalysis and body fluids. We are going to have that M spike in the protein electrophoresis, and then in the immunofixation electrophoresis, we're going to see which monogammopathies we have. And then last but not least, we're going to send out the immunoglobulin free light chains. I actually think we started recently doing this here at St. Luke's rather than sending it out, but don't quote me on that. If we have started doing that, it's been very, very recently, like within the last month. But what this test does is going to quantify how many light chains there are and the type of light chains that we have. And then we have the radiology testing as well. That's really important for us to evaluate multiple myeloma patients. These are going to have x-rays and MRIs, which are going to show the significance or maybe how significant the lytic bone lesions are. So unfortunately, there's really no cure for multiple myeloma. Sometimes we use chemotherapy with alkylating agents to kind of like suppress it a little bit. Sometimes we use radiation for some of those lesions, such as the vertebrae. And because remember, we have those plasma um, conglomerates, they really kind of form like plasma cell tumors in the those plasmacytomas. They can settle in soft tissues, they can settle in bone. So what will happen is you'll see like these plasma cell tumors form in various parts of the body, and that can cause a lot of other issues for the patient in addition to what they're already suffering with. Um, Now, there are some allogenic transplants for younger patients. And when I say allogenic stem transplants, I'm talking about allogenic stem cell transplants. There are some high dose chemotherapies with autologous bone marrow or stem cell transplants, and they actually still use this. We didn't talk too much about it, but I did mention that I have a friend who has multiple myeloma, and he actually did an autologous bone marrow. Now, um, most of the time, these people have a life expectancy of about 3 years. He's going into his fifth or sixth year with this. So apparently it has helped him prolong his life. He was doing really well. I have seen some, um, unfortunately, I've seen kind of things taking a turn for maybe in a different direction than we were hoping, but he's still doing pretty well overall for as long as he's had this multiple myeloma diagnosis. Now, biphosphonates to reduce that resorption of the bone, and that's going to decrease the hypercalcemia and the bone pain. And then refractory disease is treated with thalidomide and Velcade. And I actually don't know if they use the I can't even speak, thalidomide or thalidomide anymore. I'll have to look into that, but that would only be used in case of refractory disease, meaning that it does not respond to normal types of treatment. Now, there is one more monoclonal gammopathy that we need to discuss. It isn't technically multiple myeloma, but it is MGUS, which is monoclonal gammopathy of undetermined significance. And we're going to see a smaller M spike on our protein electrophoresis, but patients with this smaller M spike are not going to have any other findings of multiple myeloma. They're not going to have elevated plasma cell populations in their bone marrow. They're not going to have those plasmacytomas. They're not going to have elevated serum calcium. None of those things are going to be apparent. The only thing we're going to see is that small M spike. However, up to 11% of patients who have this monoclonal gammopathy of undetermined significance will develop multiple myeloma, CLL, or some type of lymphoma within the next 5 years. So this is kind of suspicious. So another plasmacytoid or plasma cell disorder is called Waldenstrom's macroglobulinemia. And this is going to be an overproduction of monoclonal IgM. What we see in Waldenstrom's is a plasmacytoid lymphocyte infiltration of bone marrow. We see it typically in older patients, and some symptoms include fatigue, weakness, weight loss. We might have hepatosplenomegaly. We might have enlarged lymph nodes. And if you think about it, that's because the proliferation of these plasmacytoid lymphocytes, all of those things, the spleen, the liver, the lymph nodes, they are lymphoid tissues. Now, I'm not saying that this is related to necessarily lymphoma, but when we have an overproliferation of lymphocytes, they utilize those lymphatic areas to continue their development. So that's why we see these elevated areas or these enlarged organs in cases like this. All right, so there might also be some hyperviscosity syndrome associated with an overabundance of those IgM immunoglobulins. So you might have neurological symptoms, blurred vision, headaches, confusion, and again, we're talking about Waldenstrom's. We may have congestive heart failure, bleeding, abnormal IgM interferes with those platelets and clotting factors, and we're going to learn more about that when we get to our coagulation. But just trust me, there's all sorts of things that can cause inhibition of platelet aggregation and function. There are things that can cause an oversensitivity and cause people to become thrombotic. Lots of things that happen. Cryoglobulinemia. So we're going to have cryoglobulins present in the blood. And this treatment, again, is not curable. We might use chemotherapy with alkylating agents, but the most effective treatment or supportive therapy we can give is plasmapheresis to remove those excess proteins. Now, the problem with hyperviscosity syndrome is that it can cause um, your blood to be kind of sluggish. And if you think about an excess amount of protein, our red blood cells flow through our microvessels, our capillaries. But if you have blockages, because you've got this huge amount of circulating, these huge amounts of circulating immunoglobulins, I mean, I could see that could be problematic. It might block blood flow, proper blood flow to some of the areas in your central nervous system, which could be why we have that those neurologic symptoms such as blurred vision, headaches, and confusion. And one more reminder, remember Babs the crab. She's crab because she has multiple myeloma. Increased calcium, rouleau/renal failure, anemia, bone lesions. Those are the important things for you to remember with regard to multiple myeloma. I hope that this recap has helped you. Try to keep those things in mind, and good luck with your studying. We'll talk more about multiple myeloma another time.